postmenopausal status, thyroid conditions, and high cholesterol, because those are things that we know increase the risk of frozen shoulder.
I'm not picking on people with diabetes, but the more severe your blood sugar tends to be the worse pain and the more severity and lasting longer.
I have this discussion all the time about what I expect to see in my patients.
Yeah, and you nailed the number one factor that I look for in diagnosis as well.
Welcome to the Shoulder Blueprint, the podcast built to help you understand the shoulder, how it works, why it hurts, and how to fix it. Here are your hosts, Dr. Caleb Davis and Dr. Justin Givens.
Hey everybody, welcome back to the Shoulder Blueprint podcast. I'm your host, Dr. Caleb Davis, and our co-host Justin Givens is back.
I'm back, baby.
After a hiatus. I'm rubbing shoulders with greatness once again, shoulder to shoulder.
Shoulder to shoulder, man.
We had Luke Braum, physical therapist, on for the last couple episodes, but Dr. Givens is back. I was saying you were saving the world one shoulder at a time.
Ooh, man, that fourth quarter of the year gets a little busy sometimes.
A lot of people don't think about it, but orthopedic surgeons get really, really busy in December because the deductibles reset, so everyone wants to have their elective surgeries done before their deductible resets.
Yeah. Also, people don't think about the fact that we have wives and kids and families and everything else, and there's more than a couple things to do around the Christmas holiday.
Oh yeah. So Dr. Givens had just, man, I couldn't believe your schedule. Since I'm a little bit new to Louisville and I'm still filling up. I was busy too, but like we had to take a little delay. But I'm excited that you're back.
Oh, it's good to be back. I'm excited to launch into this. It's time to get this thing rolling, man. We've got a couple episodes under our belt.
Did you drink your aminos? Are you ready?
I did drink my aminos. I'm fully caffeinated. I've slept like crazy because I got a couple days off. You guys are about to get me in rare form.
You look healthy. You look rested. That's good.
Yeah, a couple extra pounds from all that holiday food.
I got more than a couple. The topic I wanted to cover today was frozen shoulder or adhesive capsulitis. This is a really hot button topic. I've been delving a little bit more into the dark depths of TikTok and Instagram. It's a scary place. And this is a really big topic people talk about and people suffer from it. And I can tell you, I see a ton of it in my clinic. Probably maybe even 4 or 5 patients a week I see with adhesive capsulitis or frozen shoulder. How about you?
It's a very real thing. I mean, it could be probably one of the most common things I see that's non-surgical. And I would say too, it's one of the more painful things, surgical or non-surgical. It is very painful. A lot of people come to me and they just know they need surgery because they're hurting so much.
And talk about a symptom or an issue that drags on.
Ugh.
Like so let's break down a little bit of the numbers. So it's in general, 2 to 5% of the population may experience a frozen shoulder in their lifetime. But if you're diabetic or have a thyroid issue, that bumps up to like 20%. And we see it more often in women between the ages of 40 and 60, kind of getting close to that menopausal, perimenopausal state. So those are the people who are most affected by it.
But you really can't see it in anyone. I mean, I've had 30-year-old guys come in with frozen shoulder before, The funny thing is being older is supposed to be protective. I've seen 75-year-olds with frozen shoulder. I mean, you can see it anywhere. And it's just the whole thing of they don't know what they did. It's so funny because almost everyone has an excuse. I think it was this. I think it was this. Because they're just like, I had to have done something because it just starts out of nowhere. So they just start racking their brain. What could I have possibly done to have caused this?
And if you look up a cause of frozen shoulder, what's the number one answer? It's idiopathic, meaning we don't know the cause. There's always that joke like we're idiots. That's why they call it idiopathic. We don't know what's wrong with you. But then there's also the secondary, what we call post-traumatic or post-surgical. There's people who are in a sling after surgery, and then they have this big reactive inflammatory reaction, and then they get stiff. The distinction between the two is often difficult for me because you're usually stiff no matter what after shoulder surgery.
Yeah.
The question is, when do you call it frozen shoulder? For me, it's like if you get progressively worse, because you should be getting better. But if you get worse and worse and worse and you're not making progress, that's when I'd call it frozen shoulder after a surgery.
Yeah, for me, it's whenever it is an abnormal pattern. So when I see that your motion is limited, but especially when it's specifically limited in passive external rotation, even with some stiffness after surgery, that doesn't make sense. Like when I have patients who can lift their arm up, but it's painful, but they have like 0 external rotation with a hard stop, that's not normal. That's not what I normally see in my stiff post-op patients. And so that's when I start looking down that road and I follow them a little more closely and say, hey, let me see what direction this is going to go. But my radar is already up then that something might be going on.
Yeah, and you nailed the number one factor that I look for in diagnosis as well. People come in all the time like, I can't move my shoulder because it hurts.
Yep.
The key difference is I can't move your shoulder. Like if I take your elbow at your side, I should be able to rotate it out. I'm not a good example because I'm stiff all the time.
Yeah, I was gonna say, come on, dude, get that out there.
That's what I got right there. But if I take your arm and I'm trying to move it, it's like this. Like that's a frozen shoulder till proven otherwise to me, assuming you have a normal X-ray, like no arthritis, something like that.
Yeah.
But it usually presents sort of as a progressive pain and stiffness. It doesn't start off that you can't move your shoulder from day one, right? A lot of times it's like it's painful, it's waking me up at night, and then maybe a couple months later it's like, oh, I'm getting stiffer and stiffer. And that's how it usually presents for me.
Well, it's so funny. I have this discussion all the time about what I expect to see in my patients. So in my ladies, they come in and they realize, I can't put my bra on like I used to because I can't get my arm behind my back. I can't put my arm in a coat. I can't reach into the back seat. I can't wash the back of my hair and fix my hair. The funny thing is, I always say that there's two things that make us catch it earlier. Being a female makes you catch it earlier because whenever they start not being able to do their bra, it starts to kind of set off alarm bells for them. And it being cold. So because just the way that you have to rotate out to put a jacket on, when it gets cold in Kentucky, we catch this much sooner, I feel like. But whenever it's warm and you're not really having to put that arm back all that much, you'll have people that are like, I didn't even realize how bad it was. And then I couldn't reach over to the passenger seat to get something out of the passenger seat in the car or whatever. So it's always kind of funny. You see these same trends and same things get brought up.
It's always funny to me that as you get more and more into our practice and experience, you see the little cues and there's a pattern so you can see it a lot quicker. Yeah, the coat one's interesting because I grew up in Florida, so you didn't really wear coats. But I've been in Kentucky long enough, especially this winter. Did a lot.
Unfortunately, we wear plenty of coats around here.
Yeah, we've had a crazy winter. Let's talk a little bit about the biology of it. So what is it? It's actually more of a fibrosis. The technical word for frozen shoulder is adhesive capsulitis. Yep. In fact, someone mentioned on TikTok, they're like, we shouldn't call it frozen shoulder because you keep saying it's a flare up and it's painful and inflamed. I'm like, frozen's kind of a misnomer, right? But it's just more like it's stiff.
Yeah, it's inflamed shoulder. I mean, what I tell people is it's a wildfire that's burning out of control. Yeah. It is inflammation that's over the top. Now, the thing that makes it so much different is that a lot of inflammation, we expect it to resolve eventually. Frozen shoulder can go on to this phase where it actually starts to put down fibroblasts and scar this tissue in more. Very few things cause so much inflammation that we lose space. And that's one of the things that frozen shoulder does. You lose the volume inside the joint.
Yeah, every joint has a capsule. It's like a lining that contains all the synovial fluid, and then the tendons sit on top of that, and they all kind of blend together, and it's nice and elastic so you can move your joint. In frozen shoulder, it gets inflamed and thickened, and I talk about shrink wrap. It's like the whole shoulder's just getting shrink wrapped, so you start losing motion. And it's a normal biological response, but it's almost like it's an overdrive.
Yeah.
And there's some and again, we talked about postmenopausal. There's some links to postmenopausal women having more of an effect in frozen shoulder, but the big one is diabetes for me. The higher your blood sugar, the higher A1C, it tends to be more severe and more frequent.
Yeah, 100%. I think the way I describe it, so you talk about shrink wrap. I try to talk about the difference in normal and abnormal. So for me, I tell people, if you imagine taking your fist, and that's the top of your humerus, and you put it in a 55-gallon garbage bag, you can move it wherever you want. That's your normal capsule. And when we go in and do surgery, that's what we see is a capsule that's a lot easier to move around, a lot thinner. Whenever we start talking about frozen shoulder, I tell someone, imagine someone puts that ball right against your socket and then they put leather straps around it. I mean, it is so tight in there that they can't function. And you're exactly right. The diabetics are normally the worst because they seem to go 0 to 100 just like that. And then it just does not want to resolve. And one of the big things we use to treat it are steroid injections. And a lot of diabetics who are brittle diabetics can't have those because they'll mess their glucose up too much.
Yeah, steroid injections are largely a very safe treatment option, but people with diabetes, it tends to make their blood sugar go up. And if you have a blood sugar, say 200 after a shot, that's manageable for a few days. But if you're already sitting at 200, 300, and it shoots you up to 4 or 5, you could end up in the hospital.
Exactly. And that's the part where if you go in and talk to your doctor about this, they're going to ask a couple questions. The first one is almost always, are you diabetic? And then the next one is going to be postmenopausal status, thyroid conditions, and high cholesterol, because those are things that we know increase the risk of frozen shoulder.
And that's the interesting thing about this is that it seems to be linked to metabolic disorders. Thyroid disease, hypo or hyperthyroid, diabetes, as an insulin disturbance, and then hyperlipidemia, like you talked about, excess cholesterol and triglycerides. This is all linked. So there's some form of disorder in our metabolism that causes this, which also makes sense with postmenopausal. You're not getting the estrogen singles that can be anti-fibrotic for those females. I've done a little dive into this recently, so it's been something that's on my mind a lot lately.
Yeah.
But it all kind of checks out. There's also links to HLA-B27, which probably getting too much into the weeds, but it's a cellular immune marker that predisposes people to a lot of joint pain, ankylosing spondylitis, and other arthropathies. And that's also linked to frozen shoulder. Yeah. So there's some sort of genetic predisposition here too.
Look at this guy. I don't even know what all these letters mean, and he's just spouting them off like he knows all about them.
Man, I'm pulling it out of med school, so it's deep down there.
So smart.
But the one thing I do like to tell patients about are the phases of frozen shoulder, and I touched on that a little bit. Do you want to dive into that?
Yeah, so this is very important because it not only comes in with what we're experiencing with treating you, but it comes in with how you'll recover. So there's really 3 phases to frozen shoulder. So the first phase is the freezing phase. This is when you come to us and I tell people this sucks. Every day, it's like you're losing more and more motion. It's like a clock ticking backwards. Your arm is clicking down, your arm is clicking in, you're losing that motion.
Tons of pain, too.
Tons of pain. It is the most inflammatory phase. And that's when people come in and they're like, I have to have destroyed my rotator cuff or done something because I'm just in excruciating pain all the time. I can't sleep. Nothing's making me better. Then you go to the frozen phase. So this is where we start talking about that inflammation becoming more thickened tissue and the fibroblasts laying down thickened tissue. And people just kind of are stiff. You're not really losing more motion. And it's not that same excruciating pain, but it's just this ache all the time. They're stiff. They're not really gaining anything. They're not really improving. And then after that, we go to the thawing phase. So the thawing phase is our whole goal of treatment, is to get you to the thawing phase. And I say that, and I'm very open with my patients about that. I can't make this completely better right away. Mm-hmm. But if I can get you to the thawing phase, then every day it's like that motion is clicking back. You're gaining just a little bit, but it's much less painful and you can gradually return to function. And I always tell people, look, this is the hard part about this. Like, if you break your bone, we can put a plate on it and it's fixed back together. If you have frozen shoulder, it can still take you 6 weeks to 3 months to actually thaw if everything works perfectly. And that's the part that people don't get. They'll come back and they'll be like, hey, it's been 6 weeks. My motion's a lot better, but it's not normal. And I'm like, yeah, that's unfortunately the way this kind of works. I can't completely get rid of it overnight. We have to get you back to an area where it's improving, and then your body has to finish resolving it on its own.
That's the crazy thing about frozen shoulder is that it's one of the few things that we treat that will almost always get better on its own, but it can take up to 1 to 3 years to get better with no treatment. That's the crazy thing. Your body will eventually regulate its inflammatory phase and get back to normal, but there's reports saying 3 years with no treatment. And most people are like, I can't live with this for 3 years.
Now, so let's say this though. And here's my question, and this is me bringing the real world in. If this is such a common problem and it can last for so long, why don't we know more about it?
That's a great question. I hope you have an answer for it. You know, it's something that we see so often. You know, I think we have sort of causal links, meaning we know what it's associated with, but we don't know exactly why it starts or how we can prevent it, other than some modifiable risk factors like have your thyroid disease treated, keep your A1C down if you're diabetic. Those are modifiable factors. Yeah. But if you don't have any of those factors, I'm not sure how to tell you how to prevent this.
Yeah, and that's the thing. And this is me being just kind of realistic for you in the way the medical world works, because there's no money in it. Yeah. And that's not to be rude, but we research shoulder replacements because you can sell shoulder replacement implants. People, and when I say we, I mean companies. That's where your biggest amount of money is going to come from on this. And so, but when we start looking at things that we research things that are problems that are common, that give you long-term limitations or issues, so like permanent disabilities, and then people start bringing in money when they can make money on it. Frozen shoulder resolves on its own eventually. There's not an aggressive treatment that someone could profit off of. And so the truth is, if it's resolving and you're not permanently limited, unfortunately, people don't care. And so that's not to say that we don't care, but the people that have the money to put into it don't. And where it becomes hard then is, I would love to do a study to tell you all these things. You need such a big number I'd need millions of dollars.
Yeah.
I don't have it, you know, and so that's the part where it gets hard.
It's also, we're getting into the weeds a little bit on how clinical orthopedic research works.
Yeah.
But a lot of it's like, here's a problem, here's how we treated, here's how the patient did, and we kind of compare two groups in general. But this one's more like, we have to dig down into cellular biology, and you need like a sophisticated lab to do some of that stuff. We're talking about drawing blood and seeing how different inflammatory markers are responding or different lifestyle factors that are causing it. And I don't think we're equipped for that at our institution, even though we have a great research team.
I don't know if many are equipped for that. And that's why it's hard, right? Is you're trying to look at some of these things and say, why isn't there an answer already? Well, because they kind of have an answer, and that's for most people, it eventually gets better and they aren't permanently limited. So we're going to put our money towards something more important.
Yeah. And unfortunately, it may sound a little cynical, but that's sometimes the way the world works.
Yeah.
But, you know, part of the reason we do this podcast is try to educate people and tell them the risk factors that we do know about so they can help prevent this sort of thing.
Yep.
And this is, like I said, this is a hot button issue.
Oh,
so
this is everywhere right now.
I'm hoping that this really helps people and gives them some information. In terms of the phases, the 3 phases that we talked about, I'd give the same lecture to all my patients so they understand it. But I will caution them saying that nothing fits like a textbook perfectly.
Yeah.
I've seen people, they get that severe pain and then the pain wanes, but they're stiff. But I've seen people have ups and downs too. Like it doesn't always follow a perfect pattern. And the other thing I will say, I'm not picking on people with diabetes, but the more severe your blood sugar tends to be the worse pain, then the more severity and lasting longer. Yep. But the good news is that's something that we can target. You know, we can try to target to get your blood sugar under better control.
Yeah. I mean, for me now, if I have a patient that has an A1C of over 7, I actually send them to our endocrinology fast track program like they're getting ready for surgery.
Yeah.
Because if they can drastically get that blood sugar better, my hope is that nothing needs to happen. But if for some reason they need some kind of intervention, now I know their A1C is in a better place and gives them a better chance to recover. I think it's really now we're getting into this multifaceted approach to people's problems and not just saying, hey, I'm focused on just the shoulder. This is your only problem. When I know the shoulder is made worse by some of these other issues.
And obviously the whole body matters. And I think maybe all of us could be guilty of just being singularly minded, say, I'm a shoulder surgeon, I focus on the shoulder, but I'm trying to get more involved in nutrition and supplementation and whole body health and how that affects our outcomes. And I think you are too. I think a lot of orthopedic surgeons are, which is a good thing.
Absolutely.
But so just for anyone wondering, A1C is a way we measure your average blood sugar over a period of time. So the higher that number, the worse your blood sugar is on average. So like, let's just say you average 200, a level of 200 for a month. That's going to come out to like an 8. I'm making up some kind of.
I was going to say, you know that? I have no clue what that number is.
I think it's like 8 point. It may be in the high 7s. I'd have to calculate it, but and endocrinologists can probably pull it out of their head right away.
Dude, you are on top of it with some of the metabolic stuff lately.
Yeah, don't give me too much credit.
I was say you've been doing a lot more reading than me on metabolic disorders.
Yeah, well, I want to get prepared for all the TikTok comments.
Oh, okay, gotcha. That's fair.
But so let's get a little bit into the treatment. I think we're going to do more of that in the second episode. But we talked about steroid shots. Yep. So steroid shots are one of the first line treatments because you have a direct injection of a very powerful anti-inflammatory agent directly into the shoulder joint. And that can be very helpful. Now, I have a discussion with my patients with diabetes. If they're not on insulin and they tend to have a sugar of 100 under 150, I'll say we can try it, but you need to really keep a close eye on your blood sugar. If you come into my office and you have a sugar of 300 on average, it's a no-go.
Yeah, no-go for me too.
I'm sorry. I don't want to risk that you could end up in the hospital for that.
Yep.
The controversy is how often do we inject? And I can give my answer, but I'm curious on your input on this.
Yeah, so I am, so it comes back to philosophy a lot of times and what you think. And so when I talk to people about shoulders, I'm very open. Quality of life surgeon. I do not affect things that are pertinent to keeping you alive to make your shoulder better, because your shoulder, unfortunately, does not need to keep you alive, or fortunately in my situation.
Yeah.
And
we don't take care of your heart or your lungs.
Exactly. Yeah. And so like same thing with the glucose being through the roof, those patients in my book are going to therapy. They're not getting injections because I'm not going to send you into DKA because your shoulder hurts.
First, do no harm, right?
First, do no harm.
We can't be chasing after the shoulder and then shut down the rest of your organs.
Yeah. Now, as far as how often on injections, this one's tough. So I normally will not do an injection less than 3 months ever.
That's typical. Yeah.
Typical. The one exception is frozen shoulder. if I have someone that does really good, and so what I tell people is my goal is to see you on an upward trajectory, right? That's the whole goal. If I have someone that shoots up with the injection and it's about 6 or 8 weeks and they either hard plateau or start to go back down, but they've still made a significant jump, I will sometimes do an early injection to try to kind of catapult them the rest of the way through it.
Right.
But that is very rare.
Yeah. And I will say the kind of the ground rule for orthopedics in terms of injecting steroids is a 3-month window.
Yep.
And the reason for that isn't because you're getting devastating effects from steroid shots, but there is a small chance of mild tissue degradation with steroids. It's a catabolic agent. It's what it does.
That's what it does.
But it also reduces inflammatory and pain. So that's why we do it. For me, one injection for sure. Again, talking about the risk factors that we discussed, I ask every single patient I inject if they're diabetic for every condition because I want to talk about blood sugar.
Yep.
If they respond well to it, I'll do another one in 6 weeks.
Yeah.
Which is a little sooner than you'd expect. But I also tell them, we talk about risks and benefits. Everything in medicine is a give or take. There's no free lunch in medicine.
Yep.
Every single thing that we do has a risk.
And if I do an early one, it's the last one.
Yeah.
If I do an early one and that doesn't do it, we're done with injections because that is only because I'm trying to kind of ride the wave of you already taking off in the positive direction. And so if that doesn't fix it, that for frozen shoulder specifically, if that doesn't fix it, then that was it. We did our 2 and we got to talk about other options.
Yeah. So it's my fault for jumping into treatment already. So I'm going to jump backwards because I think we're going to get a little bit more into treatment in the next episode. I wanted to talk about the link between cancers, radiation, and menopause. We're getting a little bit more into unknown territory here. I'm going to warn the audience of that now. I did a deep dive on the research, and there's just not that much there.
No.
But I'm getting to this point where I'm like, okay, there's not good quality data. There's tons of people who talk about what we'll call it anecdotal reports of the association. And I think it's hard to ignore that. It's like we as physicians, we have to be evidence-based. We have to say we have good data to give recommendations. One, because it's ethical. The other, because we have to have legal coverage. Like, well, how'd you recommend this to them if you don't have any evidence to recommend? With that out of the way, I will say that on my deep dive for this episode, there is causal links between menopause and frozen shoulder in terms of severity. It's not like every single woman going through menopause gets a frozen shoulder, but there is a link. And there's a biological mechanism for anti-fibrotic effects of estradiol, estrogen, to protect you from that. So it makes sense. The same way we see that women's bone density goes down when they lose their estrogen as well.
Yeah.
Do you feel like anecdotally you've seen patients in that kind of thing we're talking about?
I don't know. And I say that just in full transparency is I don't know if I do ask about postmenopausal status. I do not ask about estrogen supplementation treatments and if they're on them.
Yeah.
And
well, it's
so
rare. It's rare for women to be on it.
Well, it is somewhat rare. And so I don't dive into that. And so it's something that I don't know. For all I know, they're all on them or none of them are on them because I don't typically ask about the estrogen treatment side.
Mm-hmm.
Now, I think that would be something maybe you dive into more if you're talking about preventative stuff, but I don't get to see people for preventative shoulder problems.
Right.
I see people when they already have a problem. And it sounds bad, but at that point, it doesn't matter. Like at that point, whether they're on estrogen or not, if they have frozen shoulder, I'm trying to treat them. That's kind of the big thing, right?
Yeah.
And so, no, it's something I definitely could be better about is diving into that more. But it's just not something I've done so far in the past. Is like, hey, who's on estrogen therapy and who's not? But that postmenopausal status does come in. I mean, that 40 to 60-year-old most common range is for a reason.
That's what we see. Yeah.
But it's so interesting that it falls off.
Yeah.
That's it makes you feel like there's got to be something related to that process of
maybe the body
menopause.
Finds some sort of equilibrium and it's less effective as time goes on.
Yeah, I don't know. And I think the big thing I would say is it's really hard when you talk about anecdotal things like this. You know, I know that people will sometimes comment, well, I had this and it worked great for me. And total respect for that. I'm so glad.
We had one guy get really angry at us about our stem cell clip because we said it didn't work.
Well, that's what I was kind of alluding to.
Yep.
So someone said that, you know, they were really upset because stem cells worked great for them. And that's awesome. I'm so glad that they worked great for them. That being said, when we look at the data as a whole, our job is to tell you what's most common for everyone. you know? And so that's like saying that, oh, I have to recommend sauerkraut to everyone because one person loves sauerkraut. Like, no, that's not the way it works. We have to look at what is most likely to help people with the least risk, the most benefit, and cost does have to play a role too, because we're real people and this is the real world. You can't just go out and drop $8,000 a month for something that might work.
Right. I have heard that if you put an onion in the bottom of your shoe, it will leach out toxins, though.
Oh, really? Oh, man. Well, I have pears in the bottom of mine today. Should I switch to onions?
I don't know what pears do.
Oh, okay. I got the wrong one, I guess. Yeah, I read the wrong thing.
I promise I'm not making fun of anybody. I really, I'm not. I have a very open mind to that sort of thing. But that's a great point. And I've even thought of coming up with a rating system of like, I'll like point up to the top of the screen, like, this is level 1 evidence. This is level 2 evidence. This is anecdotal and I can't really support it, but it's interesting. You know, like just a little ding like on the screen. So I'm still pondering that one. But
we should have like a special hat. Like we're gonna put on our anecdotal evidence hat. Like,
I mean, we could like, hey, there's interesting conversation. We just can't prove it.
Yeah. Because I mean, this is super interesting, and this is where you could do a lot of research, but on the hormonal effects and things like that. But it is expensive and it is hard to do.
Yes, it is. But what I will say is that on the estrogen postmenopausal front, I think the studies were done back in the 50s or 60s where they did these small groups that if you were on hormone replacement therapy as a woman, they said that you had a huge increased risk for developing ovarian or endometrial or cancers. And so it was a black box warning. If you do HRT for women, you may get cancer. And now we're seeing the advent of testosterone in men has just gone through the roof. Like every guy over 40 is on testosterone. And a lot of people are really enjoying the effects of that. And, you know, it's not like they're dropping dead. There is an increased risk of cardiovascular disease in that. But a lot of people have had really good health effects from being on testosterone. I think we're going to see the advent of that in women and estrogen. I really do. But as we're getting some more and more data saying it's not as dangerous as we thought, I think it could help prevent fragility fractures, falling, breaking your hip. It could maybe prevent some of this stuff.
Yeah, I think you're dead on, but my final answer is I plead the fifth because I am not educated enough on this topic to say I think you're right. I think we haven't fully grasped in medicine the use of hormone therapies and hormone treatments. I think we're still trying to figure out with people who are having their normal hormone levels understood. I think menopause and those drastic changes, I don't know that we've fully comprehended what that means.
Yeah.
And I'd have to ask, maybe the endocrinologists know, and someone's going to tell us after this video.
Yeah. Well, it's so funny, the social issues of being a doctor. It's like I can speculate, but I don't want someone to come sue me. It's like, well, he said this. I'm like, I'm speculating. And also there is so much literature being published. Dr. Givens and I, we can only keep up. Like they've done numbers to keep up with your specialty. You have to read 20 hours a day to keep up with everything's published on your specialty. We can't go reading cardiovascular journals and endocrine journals and possibly keep up with everything. AI helps kind of break it down so we can read summaries of articles. But it's just hard to be a specialist in everything. That's why we specialize. Yeah.
Well, so since we're talking about anecdotal, we talked about postmenopausal. What about cervical issues?
So you're referring to the neck issues.
Yeah.
Causing frozen shoulder?
I feel like I see a lot higher number of frozen shoulder in patients who have had some type of cervical pathology or neck pathology with nerve stuff.
I hadn't given that a lot of thought. My best guess would be that they're probably immobilizing their shoulder.
Yeah.
And because the pain is often referred down the shoulder blade, down the arm, sometimes even into the hand, numbness and tingling from a pinched nerve in the neck. Maybe they put on a sling for a couple of weeks because they're hurting, and then it may predispose them to it.
I see a lot of people after neck surgeries or who are like in the process of getting injections for nerve impingement in their neck. And I'm like, you know what? You've got some early adhesive capsulitis. We're doing injections. And thankfully their shoulder feels better, whether their neck gets completely better or not. But I see it a lot. And sometimes it's just kind of, it's part of the neck problem. But then they come in and they have that hard block to external.
It's that passive stiffness. If I can't move your shoulder, it's probably a frozen shoulder.
Unless that's not related to a neck problem. Right. A neck problem should not create passive stiffness.
You can't fake
pain.
That.
Yeah, you can't fake that.
Yeah, you can't. Even if you are like all tense, I'm going to be able to move your shoulder. But if I can't move it at all, that's the hallmark, and that's the big thing. And if you're testing your shoulder at home, that's the big thing.
Yeah.
But that's a really good point because there's the cervical pain, the shoulder pain. There's so much overlap. It's so hard to diagnose correctly. But I think it probably goes back to your body has some sort of insult to it, some kind of injury, whether it's a neck surgery or you just bump it in the door frame. And some of those people, maybe it's the HLA-B27, are just more predisposed to having this big inflammatory reaction, even though they don't even have diabetes or thyroid disorder.
And so I think the big thing to kind of like round out some of this stuff at the beginning of like frozen shoulder is, why do we talk about some of these things? Why do we talk about kind of these anecdotal things that we're looking for? And it's because if we catch this early, we have a lot better chance of getting ahead of it.
Yeah.
And
Absolutely.
so from our standpoint, if we can let you know, hey, like if you're a postmenopausal woman and all of a sudden your arm starts getting really stiff and painful, don't say, hey, in the next 4 months, it'll probably get better.
Mm-hmm.
You know, if you have cervical problems and you can't move your arm very well, it's super stiff, or you have diabetes and all of a sudden you notice you're losing motion, that's the time to go start seeking, not 3, 4, 5, 6 months down the road when you can't move your arm at all. Because sometimes if we can catch it early, we can get ahead a little quicker.
Absolutely. I think that's a great way to wrap up the first segment of frozen shoulder. We're going to talk much more about treatment options and outcomes and different ways that we help people with frozen shoulder in the next episode. So in 1 week from now, tune in for episode 2 of Frozen Shoulder.
Episode 2, frozen shoulder.
Thanks, guys, for listening. We'll see you next week. If you have any questions or want to reach out, our email address is info@calebdavismd.com. Follow me on Instagram, X, and TikTok @CalebDavisMD. And subscribe to our YouTube channel, Caleb Davis-MD. You can also follow Dr. Justin Givens @Givens Shoulder Elbow, and check out our podcast Instagram page @Shoulder Blueprint. And if you haven't yet, explore my other podcast, The Wellness Blueprint with Dr. Caleb Davis. Thanks for listening, and we'll see you next time.
The views and opinions expressed on this podcast are entirely our own. They do not represent the views of our employers or any professional organizations we're affiliated with. Nothing you hear on this podcast should be taken as medical advice. This content is for educational and informational purposes only. If you have a medical concern or health problem, please consult a qualified physician.